Okay. It's not working. Who helped me last time?
Nina.
The presentation itself should switch, but it doesn't switch there.
حالات الميدالوبلاستوما بقى اللي هي of the ciliary body بتعالجها ازاي يا حاج؟ هل
It's kind of like a
it's a
retinoblastoma of the
retinoblastoma.
ciliary, but it's treated the same concepts. Depends on the size. Perfect. Thank you. The second talk is about the current management of uveal melanoma. It's a bit a lengthy talk, so bear with me. So as you know, uveal melanoma is the most common primary intraocular cancer in adults. It's despite the advances that have been happening in diagnosis and treatment, there's still no significant improvement in mortality rates. The overall uveal melanoma related mortality is about 40 to 50% of the cases at 15 years of from the diagnosis. The new drugs really kind of achieve longevity. And like 20 years ago when I started this, like once a patient is diagnosed with liver metastasis, it was a death sentence within 6 months to 1 year from the diagnosis. But now I see patients survive 7 years after starting some sort of immunotherapy. But eventually they die. So no cure yet. So the collaborative ocular melanoma study was the first large multinational clinical trial that looked at the treatment and the prognosis in retinoblastoma. In that study, the melanomas were divided into 3 groups according to the tumor size: small, height less than 2.5 millimeter; medium, which is a wide range, which is most of the tumors we see is between 2.5 to 10 millimeter height; and larger tumors than 10 millimeters. The medium ones the results showed that there is no survival benefit of inoculation over radiotherapy. They used brachytherapy as a treatment. So from that time, it changed the concept that inoculation gives better survival than radiotherapies. And we knew later that what really influenced the survival is the mutation in the cells of melanoma. So the world drifted from inoculation into more conservative treatments, trying to keep the eye and possibly the vision. So the current treatments of retinoblastoma can be summarized here as radiation therapy, whether we're using brachytherapy or teletherapy. Thermotherapy has an kind of secondary role, and I'll come to that. Surgical resection in some cases, inoculation in very advanced cases, and currently under trial by a group called Aura Bioscience. They do virus-like drug conjugates. It's a virus that infects the surface of melanoma cells, and it has a conjugation that's activated by laser to release heat and burn tumor cells. Still under trial, and the indications so far are for very small tumors near to the macula in an attempt to kill the tumor and preserve vision. At this point, there is no systemic chemotherapy or systemic drug therapy that we can give to cure uveal melanoma. So for brachytherapy, here we refer to a radioactive source that's put adjacent to the target volume. It provides the most conformal radiation dose distribution, like the radiation comes just to surround the tumor without causing much destruction to the tissues around. So it produces least collateral radiation toxicity. The isotopes, the commonly used isotopes are iodine-125, common in North America and some places in Europe, ruthenium, Europe, Asia, and Middle East. Comes next, palladium is used mainly by a center in New York. or with another center in the United States, not commonly used. Iridium and cobalt are obsolete nowadays. So I'll talk a bit about the differences between different kinds of plaques. So iodine-125 decays into tellurium-125 with emission of gamma rays. It has a half-life of about 60 days, and it loses half of its activity. It can, because it's rays, it can penetrate deeper into tissues or higher into tumors, up to 12 millimeter, even more. And because we use multiple seeds, as you can see, you can customize the radiation field. Like you can play with the activity of the seeds, so you can shape the radiation fields according to your needs. And I'll explain that later. And the seeds are recyclable. Despite that they lose activity in 60 days, they still emit radiation, so you can still use them for shallower tumors. The cons is that it's costly because it's custom made for each patient. There is a large radiation penumbra. It's the halo of radiation outside the plaque edge is relatively larger than what we see with ruthenium, because the rays can penetrate, as I say, more into tissues. And the COMS plaques used to have a thicker lip, like 3 to 4 millimeter in height. Now we reduce them into 2 millimeters. So that thicker lip might make it difficult to put insinuate the plaque under a muscle. You always have to detach muscles. Ruthenium, as you know it here, decays into rhodium, which quickly decays into palladium with emission of beta particles. So these are subatomic particles. So they face resistance in tissue when they are emitted from the source. So they cannot penetrate much into the tumor thickness. But the advantage is it has a long half-life, more than a year. So you can reuse it for several patients. The same plaque, you can use it for several patients. It's thin, so you can push it under a muscle here or there. And the radiation penumbra around the plaque is much less, so it might be an advantage if you're treating a tumor very near to the fovea. This actually shows the difference between the three common plaques. I just want to draw your attention here is that ruthenium plaque for a tumor of average size 5 millimeter or so, if you want to achieve 85 gray at the apex, the dose to the sclera is 8 times that, in comparison to 3 times in iodine, 3.5 in palladium. So it's very hot on the sclera, and if you're putting the plaque at the ciliary body, you see more likelihood of areas of scleral thinning down the road. The collateral radiation, on the other hand, with iodine plaque is very high, so it causes more damage outside the irradiated area in comparison to ruthenium. And in terms of cost effectiveness, the most cost effective is ruthenium, and the most expensive is palladium, because the half-life here is just 17 days, and you have to have a high turnover of patients in order to use the same plaque. How do we calculate the dose to the tumor and structures? There's a computer software. Most common is Plaque Simulator, approved in the United States. Unfortunately, it's not approved in Canada. We use a different one called Pinnacle. In either case, we aim to give 85 gray to the melanoma apex, and the dose rate, which is important concept to have in mind, is 50 centigrade per hour. Like, still the plaque, you can extend the time, but within limit. You have to achieve a certain dose rate to achieve destruction of DNA. Otherwise, the tumor can give you the 85 gray to the apex over 2 weeks, but the small dose rate wouldn't achieve destruction of DNA. Now, there is a problem, that inherent problem to the plaque, is that tumors touching or surrounding the optic disc become a challenge because of the anatomical shape of the optic nerve. It's wider, obviously, outside the eye, with adding the meninges as well. So tumors touching the optic nerve might not be covered completely with the radiation halo. And the COMS study any tumor was within 2 millimeters from the optic disc was not treated with brachytherapy and was referred to be treated with external beam radiotherapy. So what happened is that eventually we evolved the deep notch plaque, and the notch is about 8 millimeters, so it can easily embrace the optic nerve and treat tumors up to 180 degrees of the disc circumference, and still you achieve extra 2 millimeter safety margin beyond the 180 if you use the deep notch plaque. The plaque depth is 6 millimeter and the width is 8 millimeter. As you see here, it's applied on the optic nerve, which shows that it can embrace the nerve easily without damage to the nerve or the surrounding vessels. And we started to see the results of that when we compare management of small tumors next to the nerve when we use the deep notch plaque, especially if the tumor is on the other side from the fovea and the papillomacular bundle, can achieve full tumor control and still keep the full vision at 20/20 in comparison to what we used to see when we use external beam radiotherapy to cover the tumor, and which will damage the nerve on its way. Another advantage, as I mentioned, of using a plaque with multiple seeds is that you can shape the radiation field. So if you have a tumor that looks oblong shape, you don't need to irradiate the entire disc, don't need to fill the entire plaque with similar activity seeds. So you can just put the high energy seeds that would treat the tumor in the axis of the tumor and put lower energy seeds outside that. So you reduce the damage to the surrounding retina. Also, the difficulty of treating a small tumor near the posterior pole. It's hard to put a small tumor and suture it behind the eye, no matter how you rotate the eye. So sometimes we use a larger plaque and just put the seeds that will hit the tumor with the required dose opposite the area that we will treat, and leave the other slits without radiation. Also, for iris tumor, you take advantage of the concavity of the plaque that sits on the convexity of the cornea, and you just put the radiation opposite to where the tumor is, so you just hit that area. That gives more stability to the plaque than putting the plaque on the edge of the cornea, where sometimes it moves or indents the cornea. So that's another advantage of what we call asymmetric loading of different activity seeds within the plaque to meet specific melanoma situations. So plaque radiotherapy has become the standard of treatment for all unifocal tumors within the eye, unilateral, whether benign or malignant. And also we apply it for ocular surface tumors, and I'll come to that in the last talk today. Second form of radiation is teletherapy, which here is the radiation sources away from the eye. Still has a role, but we try to, as I say, move away from it as possible, because the radiation from the plaque is most conformal, just hit the tumor area with the least damage to the surrounding tissues. If you have a tumor that's really encroaching on the optic nerve, like growing on the optic nerve, no matter how you put a notch plaque, you will not be able to control that. So we go straight to external beam radiotherapy. And also we do re-irradiation of recurrent melanomas that failed plaque radiotherapy. We do not go up front to inoculation. I have a paper coming soon with experience of about 36 cases of recurrence over 10 years. Instead of going straight to inoculation, we use external beam radiotherapy. You can re-plaque, obviously, but because of the adhesions in that area and the difficulty of reinserting a plaque, if you use external beam, we achieved full tumor control of the recurrence, and we could keep the eye in about 80% of the patients. So there is a role for teletherapy. Now, I'll take some time here to talk about the different kinds of external beam radiotherapy that we use for the melanoma. So teletherapy in general, the source might come from electromagnetic waves as gamma rays or photon irradiation. or charged particles like proton beam radiotherapy or electron beam radiotherapy. These are the examples. We always give the radiation in fractions. Why do we do that? Because it gives us some advantage. It permits tumor reperfusion, so that performs oxygen radicals, which helps you in destroying the tumor DNA. In addition to the beams themselves that formed oxygen radicals attack the DNA and break it. It recruits more tumor cells into cell cycle, and that achieves more cell population damage because the cells are most vulnerable in mitosis. Normal cells, when you hit them with radiation, they are less damageable in comparison to the cells in mitosis. And this is where the selectivity of radiation comes from. The more you have dividing cells, they will be damaged more than the cells in resting phase. So you allow between fractions for more cells to divide and get into mitosis so you can destroy. And it allows repair of normal tissue that received sublethal radiation dose. Now, because the source is away from the target volume, you have to consider a few things here. Like in plaque, it's easy, you put it just next to the tumor, but here you're shooting at the target away from the source. You need to achieve head immobilization, you need to achieve eye fixation, you need to focus the energy at the target volume so you don't shoot around. And you need, because in each fraction, you put the patient in the same position as the first time, so the radiation hit at the same point. How we go about that? So for head immobilization, in the past, we used to use the relocatable head frame with a mouthpiece, which was annoying, especially to elderly patients, to clench their teeth on a frame, so that prevents their head from movement. And we went into the Lexel frame that's used in Gamma knife. So Lexel frame is actually pinned into the skull bone. Like you go with screws into skull bone to achieve complete head fixation for an extended period of time. And in Gamma knife, we usually treat over 30 minutes, 40 minutes of continuous radiation. So we used to use that in the past. Currently, we use the customized face mask, which is a malleable plastic that we can shape it to the shape of the face, and it has holes, as you see, for the eyes, and it's fixed to the bed where the patient is laying flat, so the patient cannot move his head outside the face mask, and that's the one that's commonly used nowadays. For the eye fixation, there are several ways. The most common now is we ask the patient to look at a green spot, a green light at the ceiling, and we monitor the eye movement with CCTV camera during the radiation session. Now, as the radiation sessions are becoming shorter, the patient can achieve eye fixation for up to 1 minute if needed. Some machines, they have eye tracking system, as you see with refractive surgery, but they are ultra sensitive. The machine stops with the least movement, so it's not very efficient. Some use retrobulbar anesthesia, but the eye tends to drift even under retrobulbar anesthesia, depending on the tone of the muscles. The Russians use a block, retrobulbar block, and suturing the recti muscles into a ring around the eye to prevent mobility of the eye. It's just a bit cruel. And in children, we use suction cup under general anesthesia. So we can achieve eye fixation by several methods, but the most common is the first one. Now, the third is that we try to maximize the radiation to the target volume and minimize it to the surrounding tissue. So instead of using one beam that goes along the structures of the eye until it reaches the tumor, which causes damage, we do the stereotactic applications to divide the beam energy into multiple beams that converge at a target. So that gives actually better tumor coverage, and the normal tissue receives just a fraction of the entire dose, so less toxicity. And that's applied for all kinds of radiation, whether we're using photons, protons, or gamma knife. Now, we need the patient to be in the same position before each session. So it starts by taking a CT scan in the first, while the patient is on table, and all the current machines, they have a built-in CT scan. And we use that as our template. So every time the patient is put back, we move the table until the CT scan that we take before the session matches the one that we took in the first time. So we make sure that the machine shoots at the same point every time. This is called image-guided radiotherapy. Now, what are the types of the teletherapy that we use in melanoma? Proton beam, gamma knife, and mega voltage photon radiotherapy, and we have 2 machines for that. Proton beam radiotherapy comes from a cyclotron accelerated positively charged particles. These are the protons within the atoms. The advantage of proton beam is what we call it the Bragg peak. Now, these protons come from the aperture of the cyclotron at a certain velocity that you can control. So when you shoot at a very high velocity and it comes through the layers of the eye, they are so fast, or you can make it so fast that it cannot interact. It passes within the atomic or interatomic spaces without interaction with the electrons. But they decelerate over time as they approach the target volume. And when they reach the target volume, they reach the speed that they can interact with the electron and cause damage to the structure of the DNA of the tumor. And then there's no more proton to cause damage around. This is called Bragg peak. It refers to the delivery of the energy of the beam just at the target volume with nothing left to destroy the tissues around. So that's really the advantage of proton beam over other sources, where the energy is high at the exit of the source and it destroys everything on its way. And that's why it has this popularity between radiation oncologists as the best form of teletherapy. The energy is delivered at where you want it to be without causing much destructions to the tissue around. The problem with proton beam is that before you do the surgery, in order for the machine to see where you're looking at, you need to take tantalum clips, like you suture clips at the perimeter, like 2 or 3 of them around the perimeter of the tumor, and the machine is going to shoot in between. So actually take the patient, put them under anesthesia, take the suture just as you do with the pluck, and then take him to the radiation in a different session. Gamma knife radiosurgery is not commonly used around the world to treat melanoma. It's basically a helmet that has 192 cobalt sources that are kind of covered by gold shield, so it doesn't emit outside. And it's divided into 8 sectors movable by servo drive, so you can move the sectors so they can shoot at one point. And what you do is that you just open the shield so the radiation coming out of them focus into that one point. The source is cobalt 60 that decays into nickel 60 with emission of gamma rays, just like radioactive flux, but has a half-life of about 5.5 years. The advantage here is that it uses MRI for planning, so it's very precise, the area that you're going to shoot at, and the advantage is single fraction treatment, although some people use it as fractionated treatment because we no longer need to do that frame that's pinned to the skull. But the advantage of a single fraction treatment makes it excellent for organs that do not move, just like the orbital tumors or neural tumors or something near the orbital apex. You need, as I say, the disadvantage to achieve that, you need head and ocular immobilization for an extended period of time, which may be difficult for some patients. Here, because it's a single fraction, we use a smaller dose than what we use for with other treatments. It's only 18 to 25 gray. Now, the LINAC-based megavoltage photon radiotherapy. This is the most common one, most common form of external beam radiotherapy we use for the eye. It's the linear accelerator produces high energy photons in the mega electron volt level, which lose energy along the path of the beam. The beam diameter is determined by a collimator, like it shrinks the beam diameter down to 10 millimeters. And we evolved from 2D beam, like shooting from the front and the side, instead of shooting the whole energy of the beam into one beam. We divided from the front and the side to avoid damage to the crystalline lens, into the 3D uniform, which we use like 5 beams to shoot at the target, and to what we currently use is intensity modulated radiotherapy. In intensity modulated radiotherapy, it's a fascinating technology. You can shape the cross section of the beam. So it's not just a beam, the cross section is round. You have a multi-leaf collimator that changes the shape of the beam to any shape that you like. It's at the aperture of the gantry. And the beam is shaped to deliver energy at the target volume and spare the adjacent sensitive structures. If you're shooting next to the nerve, you can shape the beam to look like a D, hitting at the tumor and sparing the nerve. So the delivery of the mega voltage photon radiotherapy can be achieved either by the VMAT system, which here the gantry go and rotate around the patient 360 degree, whilst the IMRT keep changing its shape. So the beam just hits at the tumor and spares the nearby structure. Or the cyber knife, where the gantry is held on a robotic arm and it acts by stop and shoot method from different angles to cover the entire tumor. So in either technique, you're using high energy photons to hit the tumor. So the advantage of this LINAC-based photon radiotherapy is that this is the most type available. That was the original radiation therapy used. It doesn't require scleral clips, tantalum clips as in proton beam. There is no scalp in the frame for intraocular tumors. And the VMAT system that rotates around the eye takes 1 minute for the session. So it's becoming more precise and shorter radiation. Now, the disadvantage really is that this machine was not designed to treat the eye. Like the collimator that takes the tumor, the beam to the smallest is 10 millimeter. 10 millimeter is a large area inside the eye. So if you look at the isodose curves, like as you cover the tumor, you still hit a big, larger area around. So it's usually associated with more collateral radiation injury when you compare it with the plaque. So what is the difference really between brachytherapy and teletherapy? Which one to choose? As you probably suggested from my talk, is brachytherapy is superior to teletherapy. In either kind of radiation, there are radiotherapy-induced ocular toxicities. These come from direct radiation-induced cell necrosis of the adjacent normal tissue in the path of the beams, or retention of a large volume of tumor necrotic tissue. So you create an environment of inflammation. You get a necrotic, as if you're creating uveitis. You have a large area of dead tissue, and you already broke the blood ocular barrier. So there is a chance for getting persistent inflammation. Or injury of the vascular endothelium, which leads to progressive ischemia, what we know as radiation retinopathy, or if it's in the nerve, we call it radiation papillopathy, which can evolve into neovascular glaucoma. So our group did a study comparing stereotactic radiotherapy with brachytherapy for juxtapapillary tumors, and we found, yes, both give comparable tumor control rate, above the 95-97% in killing the tumor. However, there's been significantly higher toxicity when you compare external beam radiotherapy to plaque radiotherapy. And we looked at why this is happening. It's basically, if you look at this curve represents the external beam radiotherapy. So at the tumor base, tumor thickness, tumor apex, optic nerve nearby, retina at 5 millimeter, it's almost the same dose. So it hits, even with the same treatment dose, up to 5 millimeter away from the tumor. While in plaques, it goes exponentially down as soon as you come outside the edge of the plaque. So less radiation, less collateral damage with plaque radiotherapy. Now, other uveal melanoma treatments, TTT. When I was doing my fellowship like 25 years ago, 20-something years ago, it was the standard to give TTT for every patient at the edges to make sure that we controlled, and it was favored as the line of treatment for small tumors 3 millimeter or small. But long-term results showed that there is a high recurrence if you use it as a primary treatment, even for small tumors, that there is recurrence rate ranges up to 35-45% of the cases, because the tumor cells are hiding in the sclera where the laser energy do not reach there. So nobody is using it any longer, even for small tumor, or not favored as a primary treatment for small tumors. However, it has a role as an adjuvant treatment for a flat tumor edge adjacent to the optic nerve after brachytherapy. Just gives you like an extra layer of protection. It's a thin, less than 1 millimeter layer. You can always apply it there. And treatment of a small flat edge recurrence after plaque radiotherapy. If you have a geographic miss and started to see a little growth, you can apply TTT to burn that edge. Although again, the success rate of that ranges between 65 to 75% success in controlling the recurrence. So we started to see good results when we combined the deep notch plaque and adjuvant TTT for those tumors touching the optic nerve. And as I say, especially if the tumor is away from the macula, you can control the tumor with prolonged preservation of the eye and vision. Tumor resection, you are retina specialists, so you do that better than me. But we leave it for the cases when there is patient with a large tumor and he's single-eyed. So we know that if we use a high dose of radiation to treat such a large tumor, yeah, we kill the tumor, but we still kill the eye, eventually kill the vision. So in order to keep the vision, we can go for endoresection and then apply plaque radiotherapy for any residual tumor on the sclera or within the sclera. That small dose, less likely to produce radiation retinopathy down the road. But the more common indication for tumor resection really is toxic tumor syndrome. Is that, like, as I mentioned, when you do plaque radiotherapy and you leave a big chunk of necrotic tissue in the eye and it keeps causing exudation and hemorrhages and inflammation inside the eye, and no matter how you give steroids trying to control that, the only solution might be end up to do endoresection of the necrotic tumor tissue to hold the process of inflammation inside the eye. Inoculation is still indicated as a primary treatment for larger melanomas more than 18 millimeter base or 12 millimeter thickness, or secondary inoculation if you have a large recurrence anteriorly that you cannot treat with external beam, or refractory radiation toxicity patients, the eyes going down the drain, neovascular glaucoma, loss of vision. Although the tumor is controlled, we do the inoculation. As you know, with modern prosthetics, sometimes it's hard to tell which eye has been inoculated. So that was the first part, the treatment of uveal melanoma. Second part is about the advances that happen in estimation of the metastatic risk in uveal melanoma. So long ago, we recognized the risk factors, the clinical risk factors associated with metastasis in uveal melanoma. These are older age, more than 60. If the tumor has larger base and thickness, the diffuse flat profile because more tumor cells are in touch with the choroidal blood vessels, ciliary body involvement, or presence of extraocular extension. However, these might be if you're looking at a cohort of patients. You can classify these patients have more likelihood than this, but not at an individual level, because lookalike tumor may behave differently over time. These clinical risk factors have been further refined through the TNM staging. The TNM staging is a clinical way to give more information to the patient about the prognosis. So the way it works is that you put the tumor into one of the T categories based on the base diameter and the height. And then you look if there are lymph nodes involvement or distant metastasis, which usually doesn't happen with uveal melanoma. And you add a letter for ciliary body involvement and a letter for extraocular extension. And that creates a T category. And the T category puts the patient into one of the stages, which gives you a roughly 10-year survival estimation. So that's kind of a crude way in looking through clinical findings at the prognosis over 10 years, and you can provide the patient with information. Also, earlier on, we knew about the histological risk factors for metastasis. We know that epithelioid cells are more riskier than spindle. The presence of vasculogenic mimicry, where the tumor cells arrange themselves in a way to allow for the blood cells to circulate through them. Presence of lymphocytic infiltration, having back-to-back loops in the matrix of the tumor. All of these things are associated with high risk for metastasis, but they require enucleation or resection of the tumor. And that's not the trend in treating tumors, as I mentioned. It's now radiotherapy. So we stayed in the dark, not knowing at an individual level what will happen to this particular patient over time, until this paper came in the late 90s by a group in Germany, where they found that actually there are chromosomal changes that prognosticate metastasis in melanoma. They found that loss of chromosome 3 is associated with metastasis in 5 years in 50% of the patients, in comparison to the patients who did not have this chromosomal loss. So that opened the door actually to looking into more and more changes or mutations happening at the cellular level that predispose to metastasis in uveal melanoma. We started to learn that there are other chromosomal changes like 8q gain. And actually the combination of chromosome 3 loss and 8q gain is a recipe for disaster. The patient's gonna get metastasis and it's gonna get it fast. We also looked at the individual gene mutations. We know now that BAP1 mutation, which is not surprisingly, is on chromosome 3, is associated with high risk. So you can have the two chromosome 3, no losses, no aberrations, but only 1 point mutation at BAP1 can predispose to metastasis in 83% of the cases. SF3B1 is associated with late onset metastasis. EIF1AX is associated with better prognosis. Then the group Castle Bioscience in the United States, they look at the RNA expressed of these mutated genes and classify according to the molecular signature, according to the RNA, into two classes, class 1 and class 2. Class 2 is associated with significant metastasis. And even further, we look at the protein produced by these mutated DNA and RNA, and now we know about a protein called PRAME, which is overexpressed protein in skin and uveal melanoma, and it's identified by cytotoxic T cells, which opens the door in the future to immunotherapy as a treatment for uveal melanoma. So because the changes are happening at a cellular level, we started to learn about how to take biopsy from the eye before we do the radiation or after enucleation, so we can get this information, so we can get individualized prognostication, like what will happen to you in particular from your uveal melanoma. So there are several techniques, depends on the size and the location of the tumor. We can go transvitreal biopsy using the chandelier, the vitreoretinal techniques for shallow posterior pole tumors, or we can do it with the indirect ophthalmoscopy for thicker tumors in the posterior pole. You can go, if you're doing an open biopsy for diagnosis, you're taking tissue histology. You can also take some for cytology if you're suspecting a melanoma, or translimbal biopsy. Transscleral biopsy, which is my favorite technique, and I'll explain why, at the base of the tumor, and you can take a biopsy after enucleation and send it for cytology. So how do we do that? You don't need sophisticated Instruments, just a 10 milliliter syringe, the eagle tubing. We use needle. If we're going transvitreal, we use the long one, 27 gauge, or if we're going transscleral, we use the short one. And this is how we do the technique. So because we do, in Canada, we do the MLPA, which looks at the DNA, so we need to compare the changes in the genome of the tumor in comparison to the normal genome of the patient. So we take first buccal mucosa to represent the normal DNA of the patient. Then after you do your exposure of the area where the tumor is, you put your marks and you put your template plaque, the dummy plaque, and then before you put your real plaque, you start to take the biopsy. So we take the short 27 gauge needle and we mark it. I mark it at half the tumor thickness plus 1 millimeter. Like if the tumor thickness is 6 millimeter, I mark it at 4. So it's 3 millimeter, half the tumor thickness plus 1 for the sclera. So when the needle at this mark enters the eye, it doesn't penetrate all through. It stops at the center of the tumor, and the aspiration happens at the upper half of the tumor. This is where more the more genetic changes happen, more towards the apex of the tumor than the base. So this is the mark here, and I apply a mosquito forceps at the mark of the needle, and I bend it. So that angulation, that shoulder prevents inadvertent penetration of the sclera beyond that measurements that I took in the beginning. And then I go at the epicenter of the tumor, they were opposite to the highest point, and I do several dig and drill movement whilst I'm asking my assistant to do full aspiration of the 10 milliliters. That will start to suck the cells that were dislodged by this movement, and I asked my assistant to release slowly until he loses all the negative pressure. And I can repeat that as many times as I like, and I can change the digging and drilling within the tumor because I know it's always like half, like I'm in the center, it's half the thickness. So no matter how I change the direction of the needle, it stays within the tumor. And at the end, usually after the second or the third aspiration, you start to see some material accumulating at the plastic base of the tumor here, plastic base of the needle accumulating here. Also, I put a Q-tip to protect if anything leaks outside, it doesn't go down to the orbit. And another trick is that I use the stump of the muscle in that area to rotate the eye. Like normally we do the brittle sutures and rotate the eye, but that doesn't give you enough rotation to go posteriorly. So if you want to go more posterior, hold it from the stump of the muscle. That will give you further rotation so you can go into more posterior tumor. The advantage of that is that you can enter through to the tumor more than one time, so you can take as many cells as you like. Besides, that hole that you created is going to be covered by the plaque. So if something leaks out, it's going to be burnt instantly. And then you put your plaque on top of that. Now, I have two videos for two other techniques, which I need the help of our computer genius here. This one. So this is the technique. So put your chandelier. That's the long 27. And you go straight, do the suction. You're allowed one course. You don't create many holes in the retina. And you apply cryo at the end. Now, if you have a shallow tumor in the posterior pole, like this one, by the way, I use the inverter. So the picture here is opposite to what I see. I bend the tip of the needle, so I enter the tumor from the side. Because it's shallow, you cannot enter straight. You have to engage the entire bevel inside, so you do not suck vitreous. And it's important when you come out, you come straight, so you do not create a tear in the retina. Okay. So again, you don't need vitrectomy or anything. You can go straight directly into the tumor and take your biopsy. Not this one. So here. Yeah. Okay. Okay. Okay, so after the suction, we release the material into the tube of the tumor and send it for centrifugation, DNA amplification, and sequencing. And the results are graphically represented. So if you have a deletion in the tumor genome in comparison to the normal genome, it will show the location at which chromosome and what's happening exactly. Now the results we used, whether we obtained results as chromosomal changes, genomic changes, or RNA changes, can put the patient into one of the 4 survival categories of the Cancer Genome Atlas. So we have better information. But even still better is this scheme, which is the one we use in Canada. It's the Liverpool Uveal Melanoma Prognostication Online. It's available online, so it's free. And it was developed by Professor D'Amato in Liverpool and his colleagues, and it's been validated as a good prognostication tool. The advantage of that is that it combines the clinical and the genetic changes into one prognostication scheme. So you enter the tumor size, the tumor dimensions, the ciliary body involvement. You also enter the demographics of the patients, the age and sex. If the eye was enucleated, should have histopathology data, you enter epithelioid, spindle, mixed cells. And if you have the cytogenetic data about the chromosome, you enter that, and then it builds a survival curve for each patient according to his age group, the likelihood of survival over the coming 5 to 10 years. So that's an excellent, actually, we presented a paper recently in our society meeting where I compared the actual data, like patient we followed, and we knew what happened to them with what this scheme has predicted, and we found that the results are big time matching. So in conclusion, the recent modifications in the treatment algorithms of uveal melanoma have improved the rates of tumor control and reduced radiation toxicity. Block radiotherapy produced less radiation toxicity in comparison to external beam, and iodine-125 offer more versatile applications than ruthenium plaque. Prognostic tumor biopsy of uveal melanoma is currently a common practice in most ophthalmic oncology centers. Why? Because the stratification of metastatic risk based on prognostic information provides modification of the post-treatment metastatic surveillance frequency. So we no longer ask every patient every 6 months you have to do MRI, or if you have to do liver function tests. Basically, those are at high risk. We subject them to more MRI, more rigorous surveillance than those who are low risk. So In a way, it's economical. Early detection of metastasis. So once you subject the patient to frequent surveillance, once metastases happen, this early detection allows for earlier intervention and the patient to be enrolled onto one of the clinical trials, because none of the new drugs, the companies that produce new drugs, would accept the patient with the liver studied with metastasis. They want the patient with early metastasis to see the effect. So the earlier you detect by doing the right surveillance scheme, the better for the patient. And also it's a useful information for the patient and his family for life planning. So thank you very much.
نور النور ممكن. شكرا دكتور حاتم، الحقيقه برضه محاضره جميله وتقيله. طيب عندي بقى كام كومنت. يعني اول حاجه طبعا you are privileged ان عندكم customizable plugs، دي يعني حاجه في حد ذاتها كويسه. احنا هنا ما عندناش غير الروثينيوم.
ويل بوتنشال تو ستارت
يا فندم،
ويل بوتنشالز ان احنا تو ستارت كايرو يونيفرسيتي يبقى عندنا ايودين، يعني ممكن.
هي الفكره كلها في اللوجيستكس بتاع، يعني اللوجيستكس انفولد عشان نجت وان بلاج بموافقات من، احنا بتاخد موافقات من هيئه الطاقه الذريه.
اي نو. البلاك نفسه يعني الجولد والسايلاستيك اللي بتحط فيها السيدز دي بيرمننت، دي بتبقى ريسترلايزد ويوز فور اذر بيشنتس. السيدز هي المشكله. اللي انا اعرفه ان الكينج حسين في جوردن they use ايدين. How do they get the seeds? Maybe we need to approach like the nearby countries. Jordan, I'm sure they do. But as I told you, like it has many advantages: larger tumors,
أكيد.
customized field, and in the coming lecture of periocular tumors for external tumors as well. So
عندك فكره البرايسنج بتاعها ايه ولا سيدز ايه؟
السيد itself might be like $50-$60 per seed.
يعني الكيس هتتكلف مثلا ايه يعني $500-$600.
فانت هتحتاج مثلا البلاك هياخد له 10 to 12 seeds.
بس هي الفكره في المانيفاكتشرنج بروسيس بقى، ان يبقى عندك حد يحط لك السيدز زي ما انت عايز. هل هم بيعملوها ابرود
نو
جاهزه ولا عندهم فيزيست بيحط لهم السيدز؟
ايوه، احنا عندنا راديشن فيزيست هو اللي يعني انا البروسيس بتمشي كالاتي. انا بشوف ده melanoma needs a plaque. It's approved by the radiation oncologist. Yes, this patient can be treated by a plaque. فبتروح الراديشن medicine. The radiation medicine people هم اللي بيحطوا how many seeds and what is the energy. بعدين بيدوها الراديشن تكنيشن، هو ده بقى اللي بيبلت السيدز ويميجر ان هي achieving the goal. ففي براكي ثيرابي لاب بيبقى عندهم ستورج للسيدز، لان زي ما قلت هم ريسايكلبل. Yes, lose energy in 60 days, but still they can be used for a shallower tumor. The other advantage is that you can control the OR time. يعني الروثينيوم بيديكي، انت بتشتريه لسه من بيبيج اور وات ايفر، بتاتشيف الجول within 3 days. بعد سنه بتحتاج ان انت تسيبه على العين حوالي اسبوع علشان تاتشيف. فانت have to be flexible في الاو ار تايم.
always have fresh flux to use، فده طبعا advantage
لا
كبير.
انا الاو ار تايم لازم احطه يوم الخميس، اشيله يوم الخميس اللي بعده and so forth. ف I can play with the energy within to achieve this goal. يعني انا بصيت على المعمل عندنا، هم كل اللي عندهم حاجه زي رصاص بتحميهم اثناء ما بيحطوا السيدز، عندهم الستورج بتاع السيدز، وعندهم السوفت وير اللي بيحسب how many. بس it's the job of a radiation physicist. obtaining the seeds هي دي المشكله.
الحاجه الثانيه بقى الاكسترنال راديشن تريتمنت. طبعا انتوا بتشتغلوا بالبروتون بيم؟
لا، احنا بنشتغل بالميجا فولتج فوتون اللي انا قلت عليه، اللي هو الموست كومن.
اوكي، بس في سنترز كتيره بتشتغل بالبروتون بيم.
موست يوروب
راديشن موستلي ان يوروب. هنا احنا عندنا الجاما نايف، ما عندناش غير الجاما نايف هي الافيلبل.
ازاي ما عندكمش اللينير اكسلر؟ ده اللي بيستخدم في بريست كانسر والجاسترو انتستين.
هو جابوه قريب، انا عرفت في 57 لسه ابتدوا يستعملوه في البروستات كانسر الحاجات دي، بس ما فيش لسه الاتاتشمنت بتاعت العين. يعني ايفن في اسن في الجامعه هناك كانوا جابوه هناك، وكلف، هو مكلف البروتون اكسلريتور ده، اعتقد كان ثمنه عندهم حوالي 400 مليون يورو يعني.
ده البروتون.
بروتون.
اه
والاتاتشمنت بتاع العين لوحده كان ب 25 مليون يورو.
لا، انا مش بتكلم على البروتون، انا بتكلم على الفوتونز اللي هو
لا
الميجا
مش
فولتج
موجود،
فوتون.
مش موجود. اي نو ان هو مش موجود عندهم هنا، يمكن عندهم جابوا السايبر
مش
نايف
في معهد
بس.
الاورام مثلا؟
لا ما عندهمش برضه للاسف يعني. فاحنا هنا موستلي تريتمنت بالجاما نايف هي الافيلبل عندنا للحالات دي يعني، ولغايه دلوقتي مانجنج يعني الحقيقه يعني بيها. هو ده
وبتعملوا فراكشنيتد ولا سنجل
لا سنجل سيشن.
سنجل فراكشن؟
سنجل سيشن. هل بتعملوا بقى روتين بايوبسي فور اول ميلانوماز دلوقتي؟ يعني اولا النيدل اسبريشن اليلد بتاعها البوزيتيف ييلد فور هيستوباثولوجي تو كونفيرم ذا دايجنوزس قد ايه؟
فور سيتولوجي.
فور سيتولوجي ولا فور جينيتك تيستنج؟
لا، احنا بنعملها فور جينيتك تيستنج، يعني diagnosis is clinical most of the cases.
لو
بس
كونفيوزد يعني لو انت الكلينيكال دايجنوزس از كونفيوزنج
yes
بالنسبه
we
لك،
can do cytopathology، مفيش مشكله.
بالنيدل اليلد بتاعها قد ايه؟ هو ده السؤال.
ما هو لو داخل externally ab external transcleral you can do as many times until you see material like at the base of the needle.
اه
هو اللي انت محتاجه عشان تعمل السيتولوجي for genetics is hardly visible.
حاجه صغيره
like
خالص يا دوبك، حاجه بسيطه
بس
جدا
عشان cytology you need to see cells, you need to see
اه
brown material but accumulate as I say عند the base of the plastic base of the needle. So if you go transcleral, you can do as many times. You cannot go perforate into the retina if you're going transcleral. You can do 2 to 3 times until you see some like brown material accumulating. This is enough.
برضه
لا تعمل
ديبندز على
cytology and
الباثولوجيست برضه بتهيألي لازم يبقى الباثولوجي لاب.
هم بيعملوا الاميونو ستينز بتاعت الميلانوما بتوريهم على طول، يعني دايما الماتيريال لما بتبقى فيزبل للسيرجن.
يعني ما حدش يعني احنا نبعت لهم ساعات سامبلز برضه ما يدينيش كونكلوسيف دايجنوستس ان هو سسبكتنج ميلانوما. طب ما انا سسبكتنج ميلانوما يعني نفس الموضوع يعني.
بس بيعملوا اميونو هيستوكيمستري.
اعتقد فاكرين في الحاله اللي عملنا فيها بايوبسي واتعمل اميونو هيستوكيمستري وادونا يعني برضو ايه موست لايكلي. يعني انا عايز يعني كلام ثابت يعني.
yeah.
طيب اي اسئله؟ تامر.
طيب الاكسترا سكير اكستنشن في اي
ما بعملش concentration خالص. الراديشن is your aid لو التيومر beyond the margins. لو انت شايف visible extrascleral extension on table and it's not high, I can shave it and I put the plug to cover it. بس لو هو حاسس ان هو in touch بقى مع ال tissues of the orbit، لو هو at the front at the ciliary body, shave and put the plug. But if it's posterior and in touch with the orbital fat or the muscles or something, after you treat you give external beam. Eructation external beam.
هو فعلا اكستريشن دي حاجه فيري
it's middle ages يعني المفروض العالم يبعد عن هذا. External beam we use 40 gray in 15 fractions. 45
fractionated برضه.
fractionated
هم بتوع راديو ثيرابي بالبلانت.
بس انا مستغرب يا دكتور هاني ان مفيش الميجا فولتج. لا I doubt يعني ازاي بيعالجوا البريست كانسر واللانج كانسر ايه سورس اوف راديشن اللي بيستخدموه؟ must be that اللي هناك.
مشكلتنا عارف ايه كمان؟ ان هم they are not aware of ocular radiotherapy يعني خالص. يعني الوحيدين اللي aware بيها هم اللي في معهد مصر اللي هم تريند. كان في عندهم واحد سويدي زمان جانس دوت، دول aware بالجاما نايف للاي. انما غير كده مثلا انا مره كلمتهم في المركز الطبي العالمي بسالهم يعني على البوسيبل، قال لي لا احنا ما بنعملش الكلام ده. طب حضرتك تحاول تفهم، لا احنا مش عايزين.
انا اقول لحضرتك حاجه، هو يعني زي ما قلت في الاول ان المالتي ديسيبلينري ان انت محتاج يبقى معاك راديشن اونكولوجيست وميديكال اونكولوجيست وباثولوجيست قاعدين في الاجتماعات بتاعتكم هيبتدوا يعرفوا احنا بنتكلم على ايه واحنا عايزين ايه وبعدين الراديشن اونكولوجي بتاعي كان اصلا سي ان اس، يعني هو اصلا بيعالج برين تيومرز. مفيش حد اصلا متخصص اي
محدش متخصص
اونلي، بس هم بتوع السي ان اس بيعالجوا، بتوع الهيد اند نيك اللي بيعالج الباروتيد اند سو فورث بيعالجوا الاوربت. if you have somebody who does this, if you include him in your
نحاول
group
ان احنا
وتتكلم معاه ولو بروتوكولز عايزين نعمل دوس قد ايه وفراكشن قد ايه we can be in touch and
ومره ممكن انفايت الدكتور وائل عبد الحليم اللي هو في معهد ناصر يجي يقعد معانا مره كده ونتكلم معاه، يدينا حتى برزنتيشن او كده.
عندي سؤال برضه على الاندو ريسكشن، هي ما عملهاش راديشن قبل ما نعملها اندو ريسكشن خالص. انا لو عملنا اندو ريسكشن عليها
انهي حاله؟
على شرحتها دلوقتي صح؟ مفيش، يعني احنا بنعمل جاما نايف الاول.
احنا البروتوكول عندنا الحالات البلان فور اندو ريسكشن ان يتعمل لها الاول جاما نايف and then we do the endo resection عشان تبقى انت ايفن بتشتغل على irradiated tumor cells، وده البروتوكول اللي ماشيين بيه في المانيا.
ما هو ده كاننا بنعالج التوكسيك تيومر سندروم، ان انت بتخلق نيكروتيك اريا وبعدين بتشيلها عشان ما تعملش انفلاميشن. انديكيتد يس.
هي الحاجه اللي متغيره ان هم كان يعني اخر مره لما شفت هم بطلوا يحطوا بلاك على البيز في اخر العمليه، قال لك ان خلاص الراديشن بتاع الجاما نايف از انف. كان الانيشال بروتوكول انك تعمل جاما نايف اندو ريسكشن اند بلاك،
لانه هو بينكلود ذا هول ثينج
بالظبط. انما كان في ثيوري في الاول ان انت عندك انتراسكليرال سيلز ممكن ما تبقاش اتاثرت، فكانوا بيحطوا بلاك احتياطي، وبعدين ابتدوا دلوقتي ما يحطش بلاك في اخر الاندو ريسكشن.
لا هو في انتراسكليرال سيلز بس هو عالجها اوريدي،
بس هو عالجها اوريدي، ما كان الكونسبت اتغير ريسنتلي بالنسبه الميتاستاتيك يوفيال ميلانوما. بقى هل عندكم اكسبيرينس بالتبنتافاس بالدواء الجديد؟ اخباره ايه؟
ما زي ما قلت كلهم بروميسنج بيدوا لونجيفيتي بس ما فيش كيور. التبنتافاس هو دلوقتي الستاندرد اوف كير، واللي هم التشيك بوينت انهبيتورز ار ستيل يوزد، البيمبرو والنيفوليموماب اند سو فورث. في حالات بتريسبوند وبيفضل العيان تيومر فري فور فيو ييرز، بس ريباوندز هابن دي ميوتيت زي الفيروس زي الكوفيد. انت بتكنترول وبعدين ميوتيت under the effect of the drug mutate and start to regrow back. ما فيش حاجه curing yet.
صحيح. external resection عملتها كتير ولا لا؟
عملتها for cases that I was not sure if it's a melanoma or not, because انت مش عايز تسيب cells behind you، واذا كنت هتحط بلاك طب what's the point of external resection in the first place. بس الحالات مش عارف اذا كانت دي RPE ادينوما ولا melanoma في السيلياري بودي narrow base والتيومر is a bit long. يس بتعمل زي التراب دور زي الجلوكوما
وتشيلها
ده ثيرمي وتشيلها وبتبعت للسيتولوجي للهيستولوجي. والحالتين اللي شلتهم كانت واحده ميديلو وواحده كانت RPE ادينوما سيلياري بودي. Yes. Yes. Yes لأن هو العيان بيبقى داخل العيادة already الميتاستاسيس in his blood but you cannot see it. And you kill the tumor in the eye but the cells are somewhere in the liver or circulating and will show their face later and you cannot detect early cells.
بس ده بالنسبة للحالات اللي هي الهاي ريسك
طبعا هو اوفرول يعني السمول and فالميديوم سايز
هو الانسان 50% تقريبا اوفرول
40-50% at 15 years those patients die.
هي related للثيكنس اوف ذا تيومر از ويل، يعني كان ارون سينج الستادي بتاعته اعتقد كانت related
للثيكنس بس more determining is the base. لان كل ما التيومر بيس بتبقى اعرض في more exposure للسيلز دي للكرويدال سيركيليشن اكتر من الهايت.
هل كانت statistically correlated يعني زي الثيكنس قال لك كل 1 ملم في الهايت بياد 5%
ما
ريسك
دي
اوف
دي, دي,
ميتاستاسيس.
دي شيلز بيبر اللي
كان
هي
شيلز
1
بيبر.
ملم to 1 ملم.
بالظبط.
بس في بيبر بتاع الدماتو اللي هي ان اللارجست بيس diameter is the most determining factor للميتاستاسيس اكتر من السيكنس.
تمام.
which makes sense.
ميك سنس. ناخد 10 minutes بريك عشان